Namaskar. Welcome back to the fourth lecture of week 1. In this lecture, we will have a look at the common investigations done for the evaluation of sports injuries of the knee. We start with the common lab investigations. Although imaging is central to evaluating sports injuries of the knee, lab investigations support diagnosis, rule out systemic causes, and monitor complications. First, we start with the hematological tests. Generally, we advise the patient a complete blood count, ESR levels, C-reactive protein, and coagulation profile. A complete blood count generally detects anemia, any leukocytosis in cases of suspected infection, and this is also done as a baseline for preoperative workup. ESR may be raised in inflammatory or infective conditions. C-reactive protein is also a sensitive marker for acute inflammation. It can detect early post-injury or a post-operative infection. Coagulation profile is generally required before the surgery or in cases of hemarthrosis to exclude bleeding disorders. Other routine lab investigations are biochemical tests. Serum electrolytes and renal functions are essential for surgical fitness and fluid balance. Liver function tests are done to know the metabolic status of the individual. Creatinine kinase and lactate dehydrogenase may be elevated after severe muscle injury or rhabdomyolysis or contusion. Uric acid levels, serum calcium and phosphate levels help exclude crystal arthropathy mimicking sports injuries of the knee. And finally, if the joint has been aspirated, synovial fluid analysis can be done, which will tell you the cell counts, if there are any crystals present, if there is any bacteria grown, or if there is any sensitivity to specific antibiotics if it is a case of an infection. Next very essential set of investigations are the radiological investigations, which form the cornerstone of accurate diagnosis, staging, and management planning of knee injuries. They are crucial for visualizing the bones and soft tissues that are not apparent through physical examination. While the clinical examination provides the initial guidance, the imaging confirms structural involvement, rules out associated damage, and helps make treatment decisions. A variety of modalities are available, each having specific indication, strengths, and weaknesses. Before we proceed, it is important to note that radiological investigations are not substitute to thorough focused clinical examinations. We generally see most of the patients reporting to us with a MRI already done and giving some report of a tear. However, the management of the patient cannot depend purely on radiological findings alone. We start the radiological investigations with the first and the most commonly done investigation, which is the plain X-ray of the knee. This is usually the initial investigation in all acute or chronic injuries of the knee. It is useful for detecting fractures, avulsion injuries, any bony malalignment, any joint space narrowing as seen in degenerative conditions, any osteochondral lesions, or loose bodies if they are radio-opaque. The common avulsions that can be seen on an X-ray are the Segan's fracture, which is the avulsion of the lateral tibial plateau, and this injury is highly associated with the ACL tag. Then you may be able to see a arcuate sign, which is the avulsion of fibular styloid seen in the posterolateral corner injury of the knee, associated with avulsion of the fibular collateral or the lateral collateral ligament. You may be able to see a tibial spine avulsion, which suggests a ACL injury. Sometimes you may be able to see a patellar sleeve avulsion from either the superior or inferior pole of patella, which indicates injury to the extensor mechanism. Here, even if the bony speck is not visible, you may find the position of patella either riding very high or low in the knee compared to what it is when it is attached to both patellar as well as quadriceps tendon or knee. This brings us to the standard views of X-ray that are generally done. An AP view is generally done in a standing position, and this is important since it can evaluate joint space as well as alignment. A lateral view is done primarily for knowing the extensor mechanism or the tibial plateau and femoral condyles and soft tissue effusions. A tunnel or a notch view is done to see for any lesions in the intercondylar region. It can also detect osteochondritis dissecans and cruciate ligament avulsions. These X-rays show how a tibial slope is calculated and how the parameters for patellofemoral issues like the insult-salivity ratio, etc. are measured. These are useful for preoperative planning in certain conditions. This next slide shows the various bony avulsions as discussed, that is, a Seagon fracture, arcuate sign, and tibial avulsions. This next slide shows the extensor mechanism injuries. The first is the normal lateral view with the normal position of patella. The second is a quadriceps tendon rupture from the upper pole of patella, resulting in a condition called patella baja, which means the patella is at a lower level than the normal. This is because of quadriceps tendon is now absent and the patella goes down. The third X-ray shows patellar tendon rupture from the lower pole of patella, and the patella you can see in this X-ray is riding very high, and this condition is called patella alta. The next investigation that is commonly done in sports injuries is called orthoröntgenogram or a scanogram. This is basically a long leg radiograph which covers all the three joints of the lower limb, that is the hip, knee and the ankle, and done in a standing position. This generally shows the mechanical axis of the lower limb, and this is especially important in chronic sports injuries causing malalignment and where certain osteotomies or corrective procedures are planned. It guides management in athletes with ligament injury associated with varus and valgus malalignments. The next investigation that is popularly done is a computerized tomography or a CT scan, which is a versatile and a non-invasive investigation. It provides cross-sectional detailed anatomy which is much superior to the X-ray. It is done in cases of complex fractures of tibial plateau, distal femur, patella, and it shows fracture lines and fracture fragments and their displacement. It can easily pick up avulsions of ACL, PCL, collateral ligaments, and tendinous avulsions from the bones. It can also pick up subtle osteochondral fractures that are not usually visualized on a plain X-ray. The bony morphology, especially in case of trochlear dysplasia, which is seen whenever there are cases of patellar instability, are better seen on a CT scan. It helps in preoperative planning for fixation of various fractures. It also helps for post-op evaluation of tunnel placement or hardwares or any complications of surgery. There are certain situations where MRI cannot be used, such as when metallic implants have been used. However, these days, since most of the implants are MRI compatible and non-metallic, one may contemplate MRI. Then 3D reconstructions after a CT scan generally enhance accurate surgical planning. Despite its advantages, CT scan has certain limitations. It exposes the patient to large amounts of radiation. It has limited role for soft tissue visualization of ligaments, tendons, menisci, where MRI is definitely much superior. It cannot assess bone marrow edema or early stress injuries. Now, this slide shows how subtle injuries can be picked up on a CT, which can be measured on an X-ray, like the fibular avulsion of LCN or the ACL avulsion injuries. Another investigation that can be done is a CT arthrography. This is an alternative when MRI is contraindicated, such as in cases where a patient has other metallic implants or has a pacemaker in situ. This investigation uses the injection of intra-articular contrast to outline the edges of the menisci and the cartilage, and hence can pick up certain injuries. However, these days, with presence of MRI, this has become of limited use. CT can also be combined with angiography, and this gives a simultaneous assessment of both the bony and vascular injuries. CT angiography is indicated in high energy trauma cases or where there was a dislocation of the knee, since these cases have very high incidence of vascular injury. It helps detect any popliteal artery occlusion, any intimal tears or thrombosis in the artery. It is a rapid, non-invasive alternative to conventional angiography and is often combined with Doppler ultrasound for follow-ups in cases of vascular injuries. The next very important investigation that can be done and is becoming popular nowadays is the musculoskeletal ultrasound. This is widely available, portable, cheap, cost-effective, and dynamic imaging, and does not risk radiation exposure to the patients. This is useful for superficial soft tissue evaluations, like in cases of hamstring or quadriceps or patellar tendon injuries. It can detect meniscal cysts which are at the periphery or the peripheral meniscal tears or extrusion of the menisci after an injury. It can easily detect collateral ligament injuries. It can detect joint effusion, synovitis or bursitis. It is helpful to differentiate between a solid and a cystic swelling. And it also provides guidance for aspiration or injections that are very popularly given into the knee. However, it has certain limitations that it is very much an operator-dependent investigation. It is limited in use for intra-articular structures like the cruciate ligaments or menisci, where MRI is clearly a gold standard. A specialized form of ultrasound called Doppler ultrasound is done to assess vascular status. It is done if arterial compromise is suspected clinically following knee dislocations or severe injuries. It can also detect vascularization in a tendon tissue, which is generally indicative of tendinitis. since normal tendon is an avascular structure. This next slide shows some of the ultrasound and the Doppler images. You can see that it can easily pick up tears or discontinuity in the tendon and a local hematoma forming in the tendon or the ligament. It can also pick up disorganized fibers of a tendon that can be seen in tendinosis. And a Doppler can pick up vascularity in the tendon, which generally should be avascular and can help you make the diagnosis of tendinosis. The next most important investigation that is done in cases of soft tissue injuries or sports injuries of the knee is the MRI. MRI is considered a gold standard for soft tissue assessment in sports injuries of the knee. It provides multiplanar, high quality and high resolution imaging without the risk of exposing the patient to radiation. Its key uses are in diagnosing almost all sorts of soft tissue injuries of the knee, which includes ligament injuries like ACL, PCL, MCL, LCL, tears. It can tell the clinician the exact site and extent of tears or degeneration in the meniscus. It can detect cartilage defects, as in osteochondral injuries. It can easily pick up bone marrow contusions and occult fractures, which cannot be seen on an X-ray or even a CT. For muscles and tendon injuries, again, it can easily pick up any form of strain or rupture or the location of the exact injury, like generally in cases of myotendinous injuries, which happen at the junction of the muscle and tendon in the muscle. It can also detect synovial pathology, any fat pad inflammation, or a bursal inflammation. Loose bodies can easily be picked up by an MRI. And in post-operative cases, it is done for evaluation of any healing in the meniscus or in the ligament, or in cases of re-injury when a person has already undergone a reconstruction of the ligament. Its advantages are that it is the best modality for soft tissue evaluation, since it gives the best resolution images and tells you the exact location and nature of the injury. It can easily detect bone marrow pathology, as discussed just now, which are generally invisible on an X-ray or a CT. And the best part is this investigation does not risk exposure to large volumes of radiation, as in the case of CT of a knee. Despite all these advantages, it still has some limitations, that it is a costly investigation and it is lesser available when compared to ultrasound and CT. It is sometimes contraindicated in patients with metallic implants which are non-MRI compatible, or if the patient has implanted pacemaker, or certain patients may be claustrophobic, that is, they are scared of closed spaces, and such patients generally refuse an MRI, and hence the clinician may have to resort purely to the clinical examination or other investigations for diagnosis. And sometimes in acute trauma situation where the patient is very restless and unstable, MRI cannot be performed since it requires complete cooperation of the patient. This next slide shows how a normal ACL looks on an MRI and how a normal meniscus looks on an MRI. A meniscus is triangular in cross section and it is generally avascular, hence looks completely black. Wherever there is an injury, you can see some white streaks in the meniscus, and this indicates that there is a pathology in the meniscus. This next slide shows how clearly you can see the patellofemoral joint. The next slide shows bone marrow edema, which is suggestive of severe bone contusion, which is seen as bone marrow edema on an MRI. This is generally seen in a severe injury where you can expect other ligamentous injuries as well. Like in this case, there is a ACL tear. The next slide shows hyperintense signals in the meniscus, which is suggestive of a tear. And as we have seen earlier, a meniscus is generally avascular, so any white streaks in it generally indicates an injury. The next slide shows films where there is evidence of ACL tear along with bone contusion. You can clearly see how the PCL is lax and shows a typical question mark. A bone scan may be required if there is a stress fracture that is suspected, which is not visible on an X-ray. And it is also useful for differentiation of infection from an aseptic inflammation, especially in a post-operative case. This is a very sensitive investigation. However, the specificity is lacking, and this is generally never done alone. It is generally a complementary investigation to MRI or a CT scan. Another investigation that may be occasionally required is a nerve conduction study. This is generally done as a part of neurophysiological evaluations. This is indicated when knee trauma involves a peripheral nerve injury, such as common peroneal nerve palsy after an injury to the knee, especially dislocation or posterolateral corner injury of the knee. This helps us decide the site and type of nerve injury that a patient has sustained. Another investigation that may be required occasionally is an electromyography or an EMG. EMG complements the nerve conduction study by evaluating the muscle activity and if the muscle is denervated or not. It also detects ongoing or chronic nerve injury affecting thigh or leg musculature around the knee. It is also useful in differentiating neuropathic weakness from disuse or pain-related inhibition after the nerve injury. To conclude, I would like to say that the sports injuries of the knee require a multimodal approach which is tailored to the suspected pathology. Lab investigations are done as a part of pre-op workup, or they help us detect infection or inflammation. Plain X-rays remain the first line too, while the MRI is the investigation of choice for soft tissues. A CT and CT angiography are invaluable for complex fractures and vascular compromise. Ultrasound and Doppler provide rapid, dynamic, and vascular assessments. Nuclear scans, nerve conduction studies, and EMG are generally problem-solving modalities. And in the end, an integrated stepwise use of these techniques ensure precise diagnosis and optimizes treatment outcomes in the athletes. Thank you and Jai Hind.